Okay, here is the 2016 Next Step. This is the textbook that I use for the advanced coding. This series of videos will be going completely through this book. This textbook is very different than the other textbooks that we've had. All of this is just kind of junk. You know, I don't mean junk, but table of contents, that kind of stuff. How to use the book, that kind of thing. We're going to start with Chapter 1, Evaluation and Management. What makes this book very different than other books is it's primarily coding, not a lot of wordy stuff, not a lot of pages and pages and pages of stuff to have to read through. This book primarily gets you coding with potentially all three manuals, and that's right where we're at, and that's right the kind of practice that we need. I do want to talk about the auditing form that is used within this textbook. This is a different publisher than we had used for the basic coding. Format's a little different. How the approach to different coding theories and stuff are a little different. So I think you will benefit from having seen the information two different ways. So this particular audit form, I've put it on Blackboard so you can print it. I assume you can print it on Blackboard. It has 3 boxes on it. This is the history. These are the 3 components that we have to gather information on for the purpose of our E&M level of service. This is the history, the examination, and then the medical decision making. Across the bottom of each box has the different levels for that component. So you can determine a history, an exam, and a medical decision making, put it all together to see what your actual level is for that visit. I think this audit form will be very helpful for you to kind of see better how to determine your different components and their levels. A few things that I do want to point out. Under the history part, if you're trying to determine the past family or social history, don't worry about counting up stuff in this area. If they have a past medical history, one thing mentioned about it, it's good. Allergies is something. If they have any kind of family history, or they say that the family history is non-contributory, you have it. If they have any kind of social, are they married? That's social, that would count. So you don't have to have volumes of information, you just have to have one hit from each of these in order to get to that highest level. Or one hit from this heading, okay? So just kind of keep that in mind. Same kind of thing over here on the examination. Some areas have an OS, organ system, in parentheses, and some have a BA, body area, in parentheses. In order to get to the comprehensive exam, you have to have organ systems only. That's what this is telling you. So you would have to be pulling your information, or pulling your examination information from all of these organ systems, and then your constitutional, one or all of these count as one organ system. So you would not, in order to have a comprehensive exam, you would not have anything from your body areas. I just wanted to point that out. That's what the OS, and then the combination of BA and OS, that kind of stuff, that's just pertinent to your examination and adding up the level for that component or that examination. Okay, so this is on Blackboard. You've probably been seeing it there for a couple of weeks and maybe didn't know what to do with it, but it's there. You will see in this chapter some of the same, they will look the same to you. And this chapter will walk through, kind of go back to the basics in a very compact way on how to code the particular part of the CPT manual. This happens to be the E&M with Chapter 1. Here are, remember on the call Thursday night, I said, what are the 3 pieces of information we have to know before we can ever code anything? Place of service, type of service, and patient status. Okay? And those you already have written in your CPT. And then this just kind of reiterates or goes over again in a different way the different components of E&M. This is probably the wordiest part of this textbook is the E&M, because it kind of goes back over everything. But as you can see, here's the examination element, and it's the same as what's on your audit form. I really think that audit form will be helpful to you. This is talking about your medical decision making, your risk, contributory factors, nature of presenting illness, a little wordy stuff about each different area within the E&M section. Probably a good thing for you to go back over it, read it from a different perspective, a different publisher. Talking about a diabetic ketoacidosis and how to code that, asthma and how to code that. It does have, when you go to see the codes, it will have your ICD-10 codes first, and then there'll be a slash and it'll be your 9 codes after that, so just ignore all the 9 codes. Okay, and then now we're to our first case. This video is probably going to be a little longer than some of the other ones, E&M. I did this whole chapter and it took me almost 4 hours to kind of read through stuff, to familiarize what you guys are going to be reading, just to see if they had any updates, and then to code all the cases. And I'm a pretty fast coder, so it's a little involved. So let's start with case 1. How do you approach a scenario? This is the very first time that we've had these big scenarios. They're going to kind of be frightening probably to you at first, which is okay. But think about those key 3 pieces of information that you need. So where is this visit taking place? It's inpatient hospital. And what are they doing? Excuse me. I hope I don't start coughing or I'll just stop the video. What are they doing? They're admitting them into the hospital. It's an initial hospital care. This is an admit going in. Okay, so that should tell you exactly where you need to be within the CPT manual. You've got 3 codes to choose from. That's it. So now you have to determine the degree or the level of documentation that the doctor has given you here. So as we kind of look down, we know now where we're at and what kind of codes in CPT we're looking at. So now we kind of need to look for diagnosis codes and some treatment to see how serious this issue is. Across the board, to get admitted into the hospital, I think you have to be about dead anymore. So don't let things, unless somebody legit is unresponsive and they've done CPR and they're on the ventilator. Some of these folks look pretty sick, but the level of documentation might just be, at a level 1. Okay, so this is a 17-year-old. They have diabetes type 1. They've had issues with ketoacidosis in the past. We talked a little bit about ketoacidosis Thursday night on our call. That is very, very serious complication of diabetes. Any type 1 diabetic is going to be insulin dependent, so this medication of Humalog here, very common. I mean, that it's common because it has to be that way. A type 1 diabetic has to have insulin every day. It's not like a type 2. Medical history, type 1 diabetes, we have our asthma, and we have a medication supporting that asthma. kind of goes through some social family. I'm not going to sit and read this. It takes a lot of time. I have a social history. I have a family history. I have a medical history. I have an allergy. I have surgical. I have tons of information from a historical standpoint that I don't have to sit and read all of that. The physical, you need, if I were you, I would start right from the beginning, take this physical and plug into your audit form, compare body areas to organ systems. The difference in those is an organ system is actually going to be assessed. So take your abdomen. If it's a body area, they're going to say the abdomen is round and soft. In order to assess the organs within the body system, they would have to listen to vowel sounds. Now we're actually assessing an organ within the abdomen. It isn't just an area that has multiple organs within it. So that's kind of the thinking. So the impression that the doctor has, patient has nausea and vomiting due to diabetic ketoacidosis. They have diabetes type 1 and they have asthma. So first you have to determine your level of documentation here. Second, you have to determine your diagnosis codes that will establish your medical necessity for this hospital admit. So I would code the diabetic ketoacidosis first. That's the most serious, the most significant diagnosis on here, and it is the root of the problem for why they're showing up today. I would not code the nausea and vomiting because nausea and vomiting so sorry, is inherently a sign and symptom of diabetic ketoacidosis. So according to our guidelines, we do not code signs and symptoms when we have a definitive diagnosis. So first I would code diabetic ketoacidosis. You already have your diabetes here, and then I would code your asthma. Okay, and that's it for that one. Moving on. You will find a lot of these cases have to do with the same patient. Sometimes that can get really confusing, and I'm sorry about that. Just kind of flow with it. As you have questions, we will hammer them out on Thursday nights. Okay? 1B, this is a discharge summary. You only have 2 codes in the CPT manual for discharge. You have your 99238 or your 99239. It totally depends on time. So if there is no time documented on a discharge summary, it's automatically the 99238. So here we have vomiting with dehydration secondary to diabetic ketoacidosis, diabetes type 1, and asthma. So again, our diabetic ketoacidosis is going to be our number 1, our most significant diagnosis code. That's the root of the problem here. Their diabetes was out of control. Then they've thrown in this dehydration. And the reason I would code it next, obviously, is because I really think that it was treated and had to be watched. They had the vomiting, which obviously could make you dehydrated. They have clinical, according to the hospital course, they had a clinical evidence of dehydration. And then they even talk about what they did to rehydrate. So I do believe the dehydration in this scenario is pertinent. It happened and was medically treated. So I would code the dehydration next. Then I would code the asthma, since he lists it. Don't know too much of what they're doing with the asthma, but I would go on and list it. All right, case 2. Oh, and here was just a little bit of wordy stuff. It's good information. You might be able to get some notes out of it. Okay, case 2. Same patient as case 1. This is the emergency room visit. May have even been the emergency room visit before they were admitted. Why they have them in a weird order, I don't know. So since it's an emergency room, we automatically know where to go in the CPT manual. There's 5 codes to choose from. So all you have to do is determine the level of service based on the components. Patient comes in with the nausea and recurrent vomiting with dehydration. There's that dehydration again. 17-year-old, type 1 diabetes. Normal to have the insulin here. We have current medication, the albuterol nebulizer treatments would be a current medication for that asthma. We have a past medical history that again talks about the asthma. And then on the exam, it even tells you that the patient appears to be dehydrated. She's got sunken eyeballs and she's got a real flushed face. And then down here for the impression for this emergency room visit, it says dehydration secondary to possible ketoacidosis. We cannot code a possible. So at this moment in time, they were not sure that it was ketoacidosis. So because it's not a definitive diagnosis, we're going to code dehydration by itself. We're going to, they've thrown in this viral pharyngitis. I guess she's got a sore throat somewhere. And it says viral pharyngitis with gastroenteritis component. Gastroenteritis component really isn't going to get you a diagnosis. They're not saying she has gastroenteritis. Essentially what they're saying is she's got viral pharyngitis and her stomach's upset too, or she might even have some diarrhea. That could be from the snot from the pharyngitis for all we know, or from congestion and stuff. So there's no way to crosswalk the gastroenteritis component, no way at all. So we're going to code the dehydration. We're going to code the viral pharyngitis. We're going to code a type 1 diabetes, just generic. Do not get your E10 diabetes and your E11 diabetes confused in the ICD-10. Your E10s are your type 1s and your E11s are your type 2s. So make sure you're picking from the right place. We're going to code the asthma. And then we're going to go on and code this nausea and vomiting because that's the only real diagnosis that we have to take into account this gastroenteritis component part. Because we can't go to gastroenteritis. That's just not a full-fledged diagnosis there. So that's kind of how you walk through and why you're coding, what you're coding. I'm not giving you the codes necessarily. I'm just kind of pointing you as to why you're coding, what you're coding, at least here at the beginning. Another thing about this book, up underneath the cases, you'll see kind of some good information that'll clue you in on if there's something specific or strange about that case. Okay, case 1-3, same patient as 1-1 and 1-2. They have right lower quadrant abdominal pain. That's what they're coming in for. Our place is inpatient hospital, so they're being admitted into the hospital, initial hospital service. You can kind of flow through, do your physical exam with your audit form, figure out how many different components, how I tackle stuff. Generally, when I just kind of glance over a history like this, I think the history is going to be plenty. Most of the time we have too much history and we can't ever get to that level. So I don't sit and waste a lot of time on a history. I go to my physical exam, I count up my components there or my criteria there. Then I go to the medical decision making. That way I've kind of narrowed the playing field of what level I'm thinking I can get. And then I'll go to the history and see if I need to figure out what the history level is. Most of the time, especially on a hospital admit, you're going to have plenty of history. I wouldn't worry about it too much. You know you've got you can just kind of glance over this and see that you've got all the different components of your history. Okay, so this patient, right lower quadrant pain. The assessment is a rule-out appendicitis. There's nothing that we can do as outpatient physician-based coders with a rule-out diagnosis. So there's nothing that we can do. So instead of coding rule out appendicitis, we're going to have to go and code the symptom, which is right lower quadrant abdominal pain. The patient is also a diabetic type 1. They do have acute sinusitis and they have asthma. So the doctor has listed all of those. You will find either some type of test or medication or assessment of all of these, and that's how I would code those in that order. You do have a few discussions underneath here that are really good to read, especially for the newer coder. Here's some stuff about a rule-out diagnosis, just really good. I'm not crazy about wordy stuff, but this next step is the only advanced coding book out there, period. So it really has some good information in it. Okay, case 1-3B is a consultation, inpatient consultation. Of note, your Medicare payers will not pay any kind of consultation, whether it's inpatient or outpatient. You might just want to make a note of that. But we don't care about that right now because we're just learning. Consultation, inpatient. The reason for the consultation is pre-op diabetes management. So it appears this patient's gonna have surgery, and so they have gotten probably an endocrinologist in to assess the patient's diabetes, to see if something needs to be done before surgery, is she safe for surgery, you know, what is the diabetic status. So when you have these consultations, you only code to pay for this consultation time. So even though we know that patient has abdominal pain and asthma and sinusitis and all other kinds of stuff, your number one diagnosis is going to be to justify, establish the medical necessity for this consultation. So we know it's for diabetes management, so our first diagnosis has to be the diabetes. This patient happens to be a type 1 diabetic. That means they are insulin dependent. Another little caveat here, remember on Thursday night when we were talking about picking up a second insulin code? You only do that on your type 2s. I'm just reminding you. This is a type 1 diabetic. It is normal for them to take insulin every day. That is what type 1 diabetes is, so you would not pick up the Z79-4 for insulin. You only pick that up on a type 2 patient who has become insulin dependent. Okay, so put notes or something. Type 1 diabetes, you do not pick up the extra code for insulin. You only do that on a type 2. Okay, so on this consultation, they also add the abdominal pain, since that's the reason for the surgery, so you can code that. So you'll need to determine your level, and then you'll have 2 diagnosis codes. And there's a discussion about this. Slow going, isn't it? 3C is a radiology report. You will see different radiology reports pre-surgery for chest x-rays are always done before surgery, and then there's always the diagnosing kind of radiology reports to diagnose what might be wrong. This particular patient, this is an inpatient radiology. Doesn't matter to us that it's inpatient, but they're having an ultrasound of the right lower quadrant. And then they kind of fudge around here and they talk about some kind of tubular structure, and then it's compressible, and then it might be early appendicitis. It does kind of indicate that maybe there might be an inflamed appendix, but what I got out of this impression is they're not committing to anything. So the diagnosis code to justify for this moment in time, the medical necessity for this ultrasound, goes back to the right lower quadrant pain, because there's just no definitive diagnosis up there. 3D This is a 2-view, a PA, and a lateral chest x-ray. Indication is for cough and fever. It ends up saying there's no pneumonia, there's no effusions, it's all normal. Impression is normal. So since there was no definitive diagnosis here, you have to go back to the indication as to why they had the chest x-ray, which is cough and fever. Doesn't matter the order. If there's a sequence to the diagnosis codes, I'll let you know. If I don't mention any kind of sequence and there's multiple codes, then you can probably do it in any order. 1-4, this is an initial hospital care. Again, this is a completely different patient. Starts talking about this patient has some GERD that kind of seems to have gotten out of control, or the medication isn't holding him too well. He does have hypertension and asthma, back pain. So we've got a medical history. I do not know how pertinent those are going to be. We've got a family history, review of systems looks huge, very much, or a whole lot of information about GERD. Then here's your physical exam, which is a huge physical exam. We've got labs to go over, which would play into the complexity of your medical decision making. And then we have the plan. So the patient is going to be admitted, which we already knew because it was an initial hospital. They're going to be admitted with pancreatitis and shortness of breath. And then it goes on to tell you what IVs they're going to get, and if they're on O2, and the patient has a intense gag reflex, so they're not going to drop an NG tube on him. You know, just kind of goes on and on about that. So for this, you're going to have to determine your level of service, and then you'll have those 2 diagnosis codes. I do not see that any of this, the hypertension, asthma, I don't see that any of that is being incorporated into the admitting diagnosis. I just see pancreatitis and shortness of breath. 1-5, initial hospital, again, different patient. This is an older patient now. They have symptomatic bradycardia secondary to some medications. Anytime you have issues secondary to medications or secondary to a device that's been implanted or something like that, you're going to have several codes from a diagnosing standpoint. CPT-wise, you're going to get your history, your exam, and your medical decision-making and determine your level. Then from a diagnosing standpoint, I always kind of go to the assessment and see, hopefully, most of the time, the assessment is where you'll be able to find all your information and you won't have to go dig up other stuff. Here's your bradycardia secondary to the medications. So obviously your bradycardia is going to be first. They're specifically saying that the digoxin and some of her blood pressure medications are the problem. So you're going to have to pick up a T code, T, for the digoxin, and then a T code for those antihypertensives. So you'll have 2 T codes here. Does have a little bit of information here regarding this echo. So she's got a mitral insufficiency and tricuspid insufficiency. She's got moderate pulmonary hypertension. I don't see where any of that's being treated, so I did not code that. Not sure if your answers have it or not. Oh, that's another thing. The odd answers for these are in the back of the book, so you can always check your odds. And then I'll post the evens for you. That would be nice, wouldn't it? So I didn't code that. I don't see that it's pertinent to right now. I don't see it being treated, so I just didn't code it. The anemia would be another fairly significant diagnosis, especially if you've got a low heart rate. Your blood is not, if you're only beating, 30 or 40 beats a minute, your blood's not moving very fast. So the anemia is being treated and would be a significant diagnosis. They have a history of hypothyroidism here, but she's not on any kind of medication. So I don't see that they're doing much with that either. Same thing with the AAA here, the thoracic AAA. They say it's stable, but they're not medically managing it. Here's her hypertension. I would certainly code the hypertension. And then I would code the atrial fib. In fact, I think the answer is probably, oh wait, nope, I would not code, yes, I would code the hypertension. I remember looking at these answers now. And the hypertension, seems like the answers don't want to code it because at this time she's not getting any medicine. But it also says we have to continue to observe patient. They think the blood pressure is going to go up since they've discontinued all of the meds for right now because of the bradycardia. So I coded it because I think it's having to be watched and monitored. Okay. Moving on. This discussion will talk a little bit about those diagnosis codes that we just went over. 5B, progress report. This is the same little lady. Subsequent hospital day. Still has the bradycardia. Talks about the underlying atrial fib. Talks about the anemia that's improving. So here's also an H&H. Which adds credence to, not that you're interpreting it, but it does add some credence that they're medically managing the anemia. And her hemoglobin and hematocrit do seem to be a little low, although they're not too bad. Okay, so case 1-6. This is a new patient. Inpatient progress note. Is this a new patient? May not be. Yes, it is a new patient. Thank goodness. Okay, so here's a little bit of information regarding the patient, because you may see them later on. This is an inpatient progress report. Patient is complaining some of left ear pain. Otalgia is ear pain, and it happens to be on the left. ICD-10 does left and right, so make sure you're getting the right code. They are going to have an ENT consultation for that pain, so they're medically managing it. Patient has abdominal pain. Pancreatitis is ruled out, so you do not code pancreatitis at all. They have severe hypertriglyceridemia. Whew, huge. So that's going to be coded as well. You'll have 3 codes on this. Their left ear infection questionable. We can't code a questionable because it's not definitive, so we're back to this ear pain, and that's what I would code. Just make sure it's your left. 1-7, progress report, inpatient. More of the same. Same kind of, hopefully you're kind of getting to where, oh, okay, I think I'm kind of seeing how she does it. So I look to see what's going on with them as an inpatient progress. There's not going to be a whole lot of history because it's just from yesterday. So I generally go straight to the assessment. They have acute renal failure and they have chronic renal failure. Per our guidelines, acute is always coded first. If you have acute and chronic of something, the acute will always be sequenced first. The anemia, make sure you pick an anemia due to the chronic illness, that's CKD. Questionable small bowel, we can't do anything with that. A new onset of atrial fib, and they're managing it, so we would code that as well. I'm looking here, I've just now Noticed that the patient is status post tracheostomy. Continue inhaler treatment. So let's look over here. Does this patient really have a trach? Patient is seen not in respiratory distress. His stats are 94. That's not great. Positive bronchi. I do not see positive evidence that this patient has a trach. And I know it wasn't coded in the answers. So if you guys read this word for word and you find out that I get status post tracheostomy, that would infer to me that the patient does have a trach, but I would kind of like to see it in the physical exam. This kind of could be a funny way for the doctor to document that in the past the patient's had a trach, status post in the past, and doesn't have it anymore. So I would not code the tracheostomy unless we know that it's current today. If you do find out that trach is current, email me. Let me know, because we'll have to add that code to that. Or tell me on Thursday. You don't have to email me. This is really, really good information here. We will cover this on Thursday. This is one of those guideline things that I really, really want to hammer in. Because when you have a patient with chronic kidney disease and hypertension on the same chart, you can assume that relationship. It's the only relationship that we can assume as coders, and there's a different way to code it. So really read this and make your notes, and then ask questions if you have them. 8A, inpatient progress report. I think this might be the same. I don't know. No, it isn't. This would be a subsequent day. Abdominal pain. This is the pancreatitis ruled out, so this must be the guy from over here. 6A. They're trying to mess us up. The severe triglyceridemia. We don't do anything with a ruled out pancreatitis. We do have some action on that hypothyroid and the hypertension. He must be getting better, because now he's going to be started on some oral feeding, so that's really good. So I think you'll be okay there. Here is a discharge summary. 1.9 is a discharge summary. Discharge diagnosis is a chronic duodenal ulcer, or duodenal, however you say it. This just kind of flows, gives you a synopsis of what they did. Discharge summaries to me are pretty easy because you don't have to count up all your levels. It's a 99238 or 99239, all based on time, doesn't matter about components. And then just pick up all the pertinent diagnoses that you need, and then you're done. So I think discharge summaries are really easy. Okay, now we're kind of leaving the hospital stuff, and we're going to get into some consultations. Critical care, standby services, that kind of thing. Here is a consultation, outpatient. This is case 110, outpatient, regarding the primary care doctor is asking for this consultation to render an opinion about the varicose veins that this patient has. Gives you a little blurb about varicose veins. So that's not too hard. Just make sure that you are picking your consultation code from the outpatient and not the inpatient. 11A, another consultation, outpatient. This particular patient is preparing for a gastric resection. She has peptic ulcer disease, looks like. Impression is a non-healing peptic ulcer disease. So here's your physical to look at. Looks like there's quite a bit of history that would be easy to have to come back and pick up. Non-healing peptic ulcer disease. And there's also, let's see, they're trying to rule out all kinds of things. So as you're reading through here, make sure you don't code for something that they're just ruling out. they kind of throw out several different diagnoses, and they're not confirmed. So then they start talking about the pulmonary status. She's a smoker, and since she's going into surgery, the doctor has specifically talked about it, then you would need to put that down. And that would be your F code down here. All right. I'll probably start speeding up some now that we're kind of getting with the flow. Some of you may have just yelled at me and told me to stay slow. I don't know. Case 112, consultation, inpatient. They're being asked to render an opinion. This is a 74-year-old. She's admitted for a right-sided hemopharesis. They're assuming she's had a stroke. Just kind of flows down with what his working diagnosis is, that kind of stuff. Has a list of diagnoses here. I don't see too many of them being medically managed, so I did not end up coding them. Since this is a consultation, I only code the diagnosis that justifies this doctor for this moment in time. And the best that I can tell, this is going to end up being a really complicated case. It gets really in the weeds. But for this 12A, I would code that acute renal failure, and that's it. You're not going to want to code the volume depletion because that's secondary, or the acute renal failure is secondary because of that. So you're not going to want to code that. If they did not have a volume depletion, they wouldn't be an acute renal failure. This nephrotoxic status here, you're going to find out in like B or C or D that this patient has the renal problems because of the gentamicin that they were taking. But this is not documented great. Don't get frustrated. I know it's not documented great. So just kind of don't get into the weeds on this stuff. And we can talk this one out on our call. But if you're getting your CPT code and you're getting the basic ICD-10s here, call it good. This is this whole case, the 1A, 12A through, may go to E, was very, very, very intense and not documented great. So don't kill yourself over it. The C, they're talking about this nephritis, probably related, but they're not sure. So for this consultation, the doctor pretty much, he's talking about all this, we're assuming this and we're assuming that, and we think maybe this and all that. I would just code the acute renal failure. That is going on, and there's no wishy-washy about it. So that's what I would code for this first one. Little bit of explanation as to why you don't pick up some of the things, but it gets very convoluted in my opinion. 12B, progress note, inpatient, so this is a subsequent day. They're kind of talking about, does she need to be on dialysis or not? Is her renal failure because of the gentamicin? They just kind of are talking, they're still a little wish-washy. The husband's going to eventually decide he doesn't want her to be on any kind of dialysis, and they're going to stop care. So for this one, since they do somewhat decide that gentamicin is the problem with the nephrotoxicity and causing that acute renal failure, I would code the acute renal failure, but I would code, I think it's secondary to this gentamicin, so that's a T code for you. It was correctly taken, but she just had a terrible side effect to it. So for a CPT standpoint, you've got 40 minutes plus another 45 minutes. So you're going to need 2 E&M codes, one for that 40-minute real visit, and then another 45 prolonged services where the doctor was talking with the patient and her husband regarding the case. Counseling, trying to decide what really needs to be done here. And then on C, they ended up saying they're not doing any kind of dialysis. She does have the acute renal failure. She does have the nephrotoxicity because of the gentamicin. C and D are probable issues. They decided not to do any kind of dialysis. The doctor says, okay, so I'm going to go off the case now because they don't need me anymore, and they're just going to do palliative care. So you would need to pick your level for a subsequent progress note. I would still keep the T code for the nephrotoxicity because of the gentamicin. I would keep that as my first code because I think that's the root of the problem, which then caused this acute renal failure. So it kind of evolved from acute renal failure and we're not sure what to now we know it's the gentamicin which caused the acute renal failure. Case 113, this is a critical care note. Patient's coming in with tachypnea, so really fast breathing. I think this is the patient who is intoxicated. Nice. So the assessment, again, we have lots of history. Lots of history. Our physical exam is this part. So sorry. So we have acute alcohol intoxication. The patient is having to be mechanically ventilated, so he's intubated. Then they talk about they're putting him in ICU, all the different things that they're going to do to him. He had some hypertension, which is fairly controlled. Total time spent here, critical care. And up here, they had said critical care standpoint. So the total time critical care is 90 minutes. So in your E&M section, under critical care, that table that they have here, I'll just open it up. If I can find it fast enough. Probably should have already had it open, huh? I opened right to it. There is your critical care table. So you just plug in your 90 minutes and code it the way it says, and you're good to go. Okay, and then diagnosis-wise, you're going to have your alcohol poisoning, sadly. You're going to have your respiratory failure. What did they put respiratory-wise? What? Respiratory distress or depression is common. Mechanically ventilated. Here's need for alcohol intoxication. Vent time to observe. Yeah. And then you're going to have, on top of the alcohol poisoning, you're going to have an F code for acute intoxication. You're going to have your blood pressure. And then they're dependent on the ventilator. And this is something we talked about Thursday regarding status codes. If you're dependent on a ventilator, there's a status code for that, and that very much affects your management of care. So that's a Z99.11 that you'll have to put on there. Some discussion. Then moving into 14A, this is an ICU report. This one was a little different for me too, how their diagnosing was, and so I tried to come up with it how you guys would. Kind of was tough. This patient's in ICU. They had a recent hemorrhagic stroke involving the left frontal area, and then it says that it ended up showing a significantly large frontal lobe hemorrhage, and over here a left frontal lobe hemorrhage. So obviously this patient's had a stroke. It was finding the most specified and accurate code for the stroke that was tough, because I-62-9, I think, is just like a generic stroke code. But we know that this is actually in the frontal lobe. So when I sequenced or crosswalked this in the ICD-10, I went to hemorrhage, and then I went to intracerebral, because the frontal lobe is part of the cerebrum, and that's where the stroke took place. And I had two codes to choose from. One was, in parentheses, it said superficial, and one said deep. I don't have any indication that this was, quote, a deep stroke, that it happened deep into the brain. So I'm going to default to the superficial. But that's how I came up with this code. It's actually code I-61.1. And I'm going to give that to you just so you can kind of do some hunting and pecking, because this one was a little odd to actually find the diagnosis code. Patient is intubated, so you're going to need that Z code for the intubation. And then that's it for that one. Seemed hard, but once we got the code, we were okay. 15A, another critical care. This doctor has been brought in to manage the critical care of this patient. So kind of starts here. At this time, the patient's hypotension. With the patient's hypotension, we're going to admit into the ICU, and that kind of starts the flow. Up here's a little bit of what's happened the last couple of days. Here's your physical exam to count up on your audit form. The assessment here is the alcoholic cardiomyopathy, the CHF, pulmonary hypertension, and chronic renal. So one code that was not included here, and it would have to be, and why the answers don't have it, I don't have any idea. But a diagnosis code, if you have alcoholic cardiomyopathy, you can assume the patient is an alcoholic. They would have to be. That would be the only way to get that particular code. And I want to show you in the ICD-10. We talked a little bit about this Thursday night, but this is one of those times that if you will just kind of look around the code that you're looking for, you will end up getting information to pick up another code, and you'll code more accurately. The alcoholic cardiomyopathy, I'm hoping you can see this, is I-42.6, alcoholic cardiomyopathy. We match up our words, we feel all warm and fuzzy because we actually got to match something up, and sometimes it's hard to do that. Underneath there it says code also presence of alcoholism. It's an F10. So you would need to go over to F10 and find your code. We do not necessarily have the documentation that this patient is an alcoholic, but in order for this patient to have alcoholic cardiomyopathy, they have to be an alcoholic. They could not have this particular diagnosis without having severely abused alcohol. So I would, it says here he drinks alcohol on a regular basis. He claims to have not drunk any alcohol in the last 4 days. There's been a whole lot of wishy-washy on, can we make the assumption that they're an alcoholic? If it says that, does the doctor have to actually write it out? From an HCC coding standpoint, we always pick up that second code for the alcohol dependence, for the alcoholic. So I would say probably get in that habit and do that. That code is an F10.188, F10.188, just so you have it. And then down here you've got 90 minutes, so you can plug that in for your critical care time. Yay! 16, critical care again. This one was kind of hard. They mix, when you have A, B, and C, they kind of mix the different cases together. So I like to code only what's in front of me and then add as I need to. So bear that in mind with some of the answers. This is a critical care inpatient. Here's at this time the patient appears to be hemodynamically stable. They're intubated. That's a Z code for the being on the ventilator. And then we have our examination here. All of this is our history, tons of it. Here's our examination, our assessment and plan. This patient was admitted and had a CPR done, so that is absolutely the first code that you use. You have to. That is, did I write that down there? What was this one? Yeah, I was getting mine. I thought I had put my alcoholic cardiomyopathy. I-46.2 is your CPR. They kind of talk about stuff they're ruling out an MI or a heart attack. I chose the I-46.2 CPR because this patient has underlying coronary disease, and that particular code says that there's an underlying cardiac condition. Second would be your respiratory failure. They're intubated and on a ventilator, so I would code the Z99.2 as well. Your acute renal failure, your hypertension, your type 2 diabetes, and your COPD. Your COPD would be affecting the respiratory status. I think your answers ended up having, there's 3 codes down here that they ended up having that are actually on these other cases. So I did not put them here. That's all I coded for this moment in time. Got 90 minutes, so that's how you're going to determine your critical care time. 16B, here's 40 minutes. This is an inpatient progress, but it's the same day. That's one of the reasons why they included some of the codes over here. So you've got your chronic kidney failure or chronic renal insufficiency. It's the same as chronic kidney disease. You have a hyperkalemia here that's being treated. Your 16C, you've got your hypotension. Again, this is the same day, just a different time that day. Very interesting. This is a great discussion on some of the reasons why you code what you code. If you will notice over here, there's a question mark with the cor pulmonale. They talk about that over here as being questionable, and of course we don't code questionable things, but it's a pretty good little discussion. We're getting closer. Case 117, critical care admission again. So this is an admit going into the hospital. 75-year-old, history here of what's been going on. Talk to the wife at length, some of the past medical history. Here's your physical for you to count up on your audit form. So the patient is being admitted for a rule out myocardial infarction. There's nothing we can do about a rule out. That's not confirmed. They have congestive heart failure. They have acute renal. Here's congestive heart failure again. What else are they addressing? There's 120 minutes being used. Primary reason for the admit is hypotension, so that's a low blood pressure, and your respiratory failure. So this assessment here, this is kind of a little bit different kind of documentation. This is why it's really important to read critically. The patient's being admitted primarily for the hypotension and respiratory failure, plus the congestive heart failure, plus the acute renal failure. So kind of interesting how that worked out. And then you'll have to determine, well, you've got 120 minutes of critical care time, so you don't really have to determine the level. That makes that easier. Okay, moving out of critical care, we're getting into office and outpatient services. This will go faster. This is just a regular routine office visit, outpatient at the clinic. Patient's dizzy, they're an established patient. The assessment's hypothyroid. They're going to increase their synthroid. So that's easy peasy. One CPT and one diagnosis. Case 119, again, this is an office. This is a new patient. They're 2.5 years old, so they're with the mom, and they have some swelling, lump on her neck and stuff. So they end up diagnosing her with lymphadenopathy, secondary to an upper respiratory infection. Lymphadenopathy, really swollen glands, are not necessarily a part of an upper respiratory infection, so they wouldn't necessarily be a symptom. So I would code both of these. Again, remember, this is a new patient. Office visit, outpatient here, 2-week follow-up for lymphadenitis. Resolving lymphadenitis, it didn't say it was resolved. It is resolving. So they still have it. It's just getting better. Another clinic, outpatient, progress note, established patient. They've had some cold symptoms, episodes of vomiting. So they've diagnosed him with an upper respiratory infection with a little bit of pharyngitis. That's interesting. So you're going to have 2 different codes there. You don't necessarily have pharyngitis with an upper respiratory infection, although I think my pediatric docs would disagree with you. But who are we? Okay, out of office, moving into hospital observation. 20A, this is a hospital observation for acute diarrhea and volume depletion, 52-year-old, known chronic renal failure, also has lupus nephritis, and the only thing they're presuming here is that the chronic renal failure is related to the lupus. He has chronic renal failure and he has lupus nephritis. They're just presuming that they're linked. I keep calling her a him. She was thought to be dehydrated in the emergency department. So here is the impression. Here again is that's past medical history. Some of it is pertinent to today. So you've got your acute diarrhea. You've got your metabolic acidosis. I wouldn't necessarily code. I think that is a symptom. You have your uncontrolled hypertension. So let's see here. The metabolic acidosis is from the diarrhea. I think this patient their number one diagnosis is going to be dehydration. And that's because of that acute diarrhea. So I would code a volume depletion first. They're going to give her quite a bit, 3 liters of fluid here, which is quite a bit of fluid. So I would code this, the number one diagnosis, as a volume depletion. Then I would pick up that diarrhea. Your hypertension, you're going to want to code that, put your hypertension in front of the CKD, and then you're going to have your lupus nephritis. I don't know. I think I am going to go in and pick up that metabolic acidosis. I like it. I think it's pertinent. And it's secondary to the diarrhea, just like the dehydration is. So I think we need to pick that up. Okay, moving into neonatal services. 21, this is newborn care, inpatient. You have to turn the page. This is kind of a weird one to fill out. You're going to have a data service up here. 1, 2, 1, 3, 1, 4, and 1, 5. So you have 5 dates of service on here. It's kind of weird how they've written this out, but I guess there wasn't any other way to do it. So for a CPT, you're going to have your initial newborn services, and then your subsequent days, and then your discharge. On 1-3, you've got a circumcision in there. So you're going to code that in addition. So you're going to have to use a modifier, because remember, on the same date of service, the doctor can't get paid twice for a service unless it's justified. So we're going to have to put a modifier 25 on the subsequent newborn code so that he can get full price for his circumcision code. Diagnosis-wise, you're gonna have that Z3801 newborn born by a C-section. I believe that's what this one is. Is it a C-section? Got it. Yep. By means of C-section. Make sure you read this part. I love this book, but it sure can get confusing for a new person. Case 122, hospital services, inpatient. This is a delivery room. This is a preterm baby. We're going to have lots of diagnosis codes on this. I can totally hear us talking about this on one of our Thursday calls. Baby was born at 30 weeks gestation, and their weight here. Lots of history on stuff. Essentially, it's a premature male infant. So your CPT is going to be your 99464. Oh, I just gave it to you. Sorry about that. And so your diagnosis codes, you're going to have to kind of stack them. Always with preemie babies, you have to give the weeks of gestation, and you have to give their birth weight. So I'm probably going to give you the codes here to begin with, and then I want you to take those codes and go research them and figure out why we coded them. Okay, so it's a premature baby infant, but that's not the biggest problem. They have respiratory distress because of a hyaline membrane disease. So that's going to be your first diagnosis code, P22.0. Then you're going to have that low birth weight, P07.17. You're going to have your preterm, your 30 weeks of gestation, P07.33. You're going to have your, the mom was really high on magnesium, and it's elevated magnesium in the baby as well. That's at P71.8. And you notice all of these are P codes because this is the baby's chart. If it was an O code, it would be the mom's chart most of the time. Okay, so then they've also put them in observation, watching them for septicemia or sepsis. So that's Z03.89, observation for a specified condition. And then your Z3801, because it's a newborn born by C-section. So these codes are going to kind of keep reproducing themselves through the rest of these cases, most of it. This is a progress note, subsequent day, so change your critical care subsequent day. And then most of these diagnoses, I think they're all the very same as over here. I think what I added on this was that the baby was ventilator dependent, obviously. So I would add the Z99.11 if you have documentation of the ventilator dependence. 22C, Still the same baby. This is another subsequent progress report. So you need your CPT is going to be your critical care subsequent. Diagnosis codes are a little bit different on this one. So you still have your hyaline membrane. You still have your preterm weeks and weight. Now we have a patent ductus arteriosus coming up. That's a Q25.0. We also have increased bilirubin, so the baby's getting jaundiced. This note does not say jaundice, but if you go to the ICD-10 index, look up hyperbilirubinemia in newborn, which this is, it's going to tell you to go to jaundice. So that's how you get the P59.0. Patient also has some mild thrombocytopenia, that's P61.0. Remember, if you can, to get your codes pertinent to a newborn. You wouldn't want thrombocytopenia of an adult if you have that choice. If you have the choice of a newborn, okay. And then again, if they're ventilator dependent, add your Z99.11. And then this 22D is the last. For this little baby, which I was kind of happy about. Again, it's mostly the same type of codes that you've already coded. So I'm not going to give them to you again. Okay, now preventive services. Preventive services are generally when people encounter medical or healthcare and they're not necessarily sick. They're there for a checkup or to get their cholesterol checked or a mammogram. You know, they don't have any symptoms, but they're going in for just a routine maintenance of something, pap smears, that kind of thing. Used to be in ICD-9 world, these were what we called V codes. Now we don't have, well, we do have V codes, but they don't mean the same thing. These are actually Z codes now. Nothing like trying to just confuse us to all heck. So 23A, office visit. Patient is in for a PAP and a physical. And they kind of go through here and they end up addressing less like a GYN physical and more like a regular doctor visit physical. So even though the doctor notated that it was a normal gynecological exam, this doctor has done a complete body exam, not just of a GYN nature. So I would code this with the Z00.00. Not the gynecological one. And we'll see a gynecological one in just a minute. And then the patient also has hypothyroid and is also overweight. 23B, again, this is a healthy patient a year later. So same type of codes there. Now, what I don't like about this scenario here, we have a preventive visit 1 year, a year later a preventive visit. Insurances only pay those preventive visit codes one time a year, period. Some insurances don't even pay them that often. So here on 23C, we have the same patient returning 2 weeks later for a college physical. So according to the answers, they have us coding it with the same preventive code. I guarantee you the insurance company is going to deny it, even with a different diagnosis code. So I just wanted to throw that out. We're going to go on and code it. We're not worrying about getting a claim paid right now. We're worrying about passing the CPC board. But I just wanted to throw that out, that this is not 100% correct coding because I know that insurance isn't going to pay. So the point of this is for you to find the school physical, which is a Z02.0, and then the patient still has that hypothyroid. Okay? So that was my little soapbox. I just got off it. It's okay. 24A, outpatient. Again, this is a physical exam. The patient has hypertension, also smokes. Anymore with ICD-10, if you're a smoker, I probably wouldn't tell your doc because it's going to get on your record and travel. And it's travel with you from then on. If that doesn't bother you, then I guess it's okay. This is an annual checkup. They're kind of doing a head to toe. So again, this is just a routine, patient's not sick, routine examination. They do have hypertension, I get that, but it's completely under control with the treatment, so he's not sick with it. 25, office visit. Patient's in for a checkup. She's now a year old. She's an established patient. So pick your preventive visit for the right age. And then because this is a kid, you're going to have a different examination code from an ICD-10 standpoint. 26A, this is a pelvic exam and a pap smear. So you will see that the examination and the focus of this exam is going to be very different than when the physician did a pap smear, but all this other stuff. This is 26A is very, very gynecologic. That's all the doctor is assessing. So make sure you pick the ICD-10 diagnosis code for the gynecological visit. And then we are into our auditing reports. At the end of every chapter in this textbook, they have 3, 4, 5, 6 different audit reports. And you can do them or not do them, doesn't matter to me. The practice in doing them is, if you read critically through and then look at the answers, what they've pre-populated, then you get to decide what they've done incorrect. And it's just a different angle in helping you critically read and figure out how to sequence things and code things and that kind of thing. If it were me, I would do them. I think it's great practice for you. But that's what, there's several of them. They've added some this year, which is good. Okay, the next video will be medicine section, and it won't be as long, I promise.